Welcome to ICU Primary Prepcast.
Hi, I'm Maddi.
Hi, I'm Swapnil, and today we are going to continue our third episode of Antibiotic podcast, that is Antibiotics Part 3. And, there was Easter break, and I hope you had a nice break. What did you do in your Easter break?
So I ate a lot of chocolate, ate some hot cross buns, went to a wedding, but mainly it was eating, a lot of eating.
Good. Now it's time to go and hit the gym.
Yeah, that's right.
So let's start with the case scenario. A 58-year-old gentleman presents to hospital with a 5-day history of cough, fever, and shortness of breath. He is quite tachypneic, hypotensive, and hypoxemic. And on chest X-ray, he does have some right lower lobe consolidation. So, as per the policy or guideline, you have commenced him on ceftriaxone and azithromycin as an empirical treatment for severe community-acquired pneumonia. Now, can you please explain why is azithromycin a part of recommended antibiotic regime in this case?
So, empiric therapy for community acquired pneumonia aims to effectively cover the pathogens most likely to be responsible for the disease. So, the majority of bacterial community acquired pneumonia in Australia are caused by pathogens susceptible to penicillin, such as Streptococcus pneumoniae. However, the disease severity plays a crucial part in determining the antibiotics used because patients with severe community acquired pneumonia have a much higher risk of adverse outcomes if they are not given appropriate treatment. Consequently, broader spectrum antibiotics are utilised in this cohort until the offending pathogen is identified. Bacterial community acquired pneumonia can be arbitrarily classified into typical or atypical, depending on the causative organism. Atypical organisms are those that are not detectable on gram stain and cannot be cultured using standard methods. The most commonly identified atypical organisms to cause community-acquired pneumonia are Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella species. Beta-lactams are ineffective against these organisms, as both Chlamydia pneumoniae and Legionella are intracellular organisms, and Mycoplasma lacks a cell wall. Therefore, azithromycin is added to ceftriaxone in order to cover these atypical organisms.
Good. And are there any alternatives to azithromycin?
Yeah, so doxycycline can also be used, but is only available in oral formulations, which can make it difficult to use in the critically ill. Clarithromycin, which is another macrolide like azithromycin, can also be used, but is also only available in enteral preparations.
And there are a couple of scoring system which you can use to grade the severity of community acquired pneumonia, and based on the severity you can choose the regime. So if the patient presents with mild community acquired pneumonia, you can probably get away with oral augmentin. If patient comes with moderate to severe community acquired pneumonia, benpen and doxycycline. And then if the patient comes with severe community acquired pneumonia, you probably prescribe him ceftriaxone and azithromycin as you described. So, what antibiotic regime could be used if this patient was known to have anaphylaxis to penicillin or cephalosporins?
So, moxifloxacin could be used as a single drug in this case. This is a fluoroquinolone with broad spectrum activity against both gram positive and gram negative bacteria, as well as atypical organisms. It has much better anti pneumococcal activity than ciprofloxacin. Moxifloxacin inhibits DNA gyrase and topoisomerase 4, which interferes with bacterial DNA replication, transcription, repair, and recombination, resulting in cell death. It demonstrates concentration-dependent killing. However, widespread use of fluoroquinolones has been associated with C. difficile infections and with increased antibiotic resistance. Therefore, moxifloxacin is reserved for patients with severe hypersensitivity to penicillins or cephalosporins.
Okay, now let's dive into one of the commonly used antibiotic. So, can you please outline the pharmacology of azithromycin?
Azithromycin is a broad-spectrum macrolide antibiotic with bacteriostatic activity against many gram-positive and gram-negative bacteria. It is used in the treatment of several diseases, including atypical community-acquired pneumonia, chlamydial infections, Mycobacterium avium complex infections, pertussis, gonorrheal illnesses, urethritis, pelvic inflammatory disease, typhoid and paratyphoid, traveller's diarrhea, and chronic Pseudomonas aeruginosa infection in patients with cystic fibrosis. Its pharmacology can be divided into pharmaceutics, pharmacokinetics, and pharmacodynamics. Azithromycin is available as a tablet of 500 milligrams or a 500 milligram powder, which is reconstituted for intravenous infusion. Its pharmacokinetics can be divided into the administration, absorption, distribution, metabolism, and elimination. In terms of its administration and absorption, it can be given orally or intravenously. Oral bioavailability is approximately 37% and is not affected by the presence of food. The usual dose is 500 milligrams to 1 gram daily. In terms of its distribution, it has a volume of distribution of 31.1 litres per kilogram, with a much higher concentration in tissue compared to plasma. The lung, tonsils, and prostate have particularly high rates of azithromycin uptake. Azithromycin is also concentrated within macrophages and polymorphonucleocytes, but it has poor penetration into CSF and peritoneal fluid. The metabolism of azithromycin has not been elucidated, and it's excreted in the bile primarily as unchanged drug. Only 6% of the administered dose is excreted unchanged in the urine. The terminal elimination half-life of azithromycin is 68 hours, and no dose adjustment is required in renal impairment. Due to its prolonged half-life and slow release from tissue sites, it is able to be given as a shorter course compared to most other antibiotics. Now onto the pharmacodynamics. Azithromycin binds to the 50S ribosomal subunit in bacteria, which then inhibits protein synthesis. It is also thought to have some anti-inflammatory and immunomodulatory effects, which is why it is sometimes prescribed in chronic respiratory inflammatory diseases. Azithromycin displays time-dependent killing with prolonged, persistent antibiotic effects. Therefore, its efficacy depends on the total concentration of the drug achieved over 24 hours above the MIC of the organism. Adverse reactions include gastrointestinal symptoms, headache, dizziness, QT prolongation, and hearing impairment. It is a category B1 in pregnancy. Unlike clarithromycin, azithromycin does not interact significantly with the hepatic cytochrome P450 system and consequently has minimal clinically relevant drug interactions. However, due to its QT prolonging effects, it should be used in caution with other drugs that prolong the QT interval.
Yeah, that's very important because most of the agents that we use in intensive care unit can have the potential to prolong the QT. Another important fact about azithromycin, if you give azithromycin for 3 days, actually the plasma concentration remains quite high till double the time, that is 6 days, so 7 days. So usually consider stopping azithromycin early because that will still give adequate coverage for next few days. Now let's move on to the next scenario. A 22-year-old female with a history of intravenous drug abuse presents with a 2-week history of fever, arthralgia, and lethargy. On examination, she is febrile up to 39 degrees Celsius with a pansystolic murmur which can be heard loudest at the left lower sternal border. She is commenced on vancomycin and gentamicin as empirical therapy for suspected infective endocarditis. Why do you think the vancomycin has been chosen in this case?
Empirical therapy for native valve endocarditis is usually benzoyl penicillin plus flucloxacillin plus gentamicin. However, in patients with a high risk of MRSA endocarditis, such as those who inject drugs, vancomycin is recommended to cover MRSA.
Good. And what are the common organisms that are responsible for infective endocarditis?
So the common organisms are Staph aureus, which can be either methicillin sensitive or methicillin resistant staph, coagulase negative staph, such as Staph epidermidis, Streptococcus viridans or Streptococcus bovis, Enterococcus, and the Hay-Sec organisms. So these organisms are gram-negative bacteria, which are commensals of the human oropharynx. They are an acronym which consists of Haemophilus species, Agretiobacter acetinomyces concomitans, Cardiobacterium hominis, Echinella corridans, and Kingella kingae.
Okay, that's very complex names.
Yeah.
Now, can you please compare and contrast the pharmacokinetics and spectrum of activity of vancomycin and gentamicin?
So vancomycin is a narrow-spectrum glycopeptide antibiotic with good gram-positive activity but no gram-negative activity, whilst gentamicin is an aminoglycoside antibiotic with broad-spectrum antibiotic activity, but which is mainly used against gram-negative bacteria. Vancomycin is active against gram-positive organisms, including staph species, Streptococcus, Enterococcus, Clostridium, Listeria, Corynebacterium, Actinomyces, and Peptococcus. Gentamicin is active against most gram-negative organisms, including Pseudomonas, Enterobacter, and E. coli, but is also active against some gram-positive organisms, including staph and strep species, and atypicals such as Mycobacterium. However, gentamycin's gram-positive cover is generally considered insufficient for sole therapy, but it does exhibit synergistic effects with beta-lactams and thus is sometimes used in combination. Gentamicin exhibits concentration-dependent killing, whereas vancomycin's antimicrobial activity depends on the total concentration of the drug achieved over 24 hours above the MIC of the organisms. The pharmacokinetics can be subdivided into the administration and absorption, distribution, and metabolism and elimination. Vancomycin can be given orally, intraperitoneally, or intravenously, but it has poor oral absorption, although this may be enhanced in colitis. It cannot be given intramuscularly. Gentamicin can be given intramuscularly, intravenously, or topically. It has very poor oral absorption and thus is not given orally, but has almost complete intramuscular absorption. Vancomycin needs to be infused slowly, over 1 to 2 hours, depending on the dose, as rapid injection can cause red man syndrome, which consists of hypotension, flushing, and pruritus. Gentamicin is also given intravenously, usually over approximately half an hour due to concerns about toxicity from high serum levels with rapid bolus dosing. However, these concerns have not been clinically proven, therefore bolus doses over 3 to 5 minutes are sometimes given in the critically ill. Both gentamicin and vancomycin doses are weight-based, with gentamicin initial doses ranging from 3 to 7 milligrams per kilogram IV, depending on the indication. Additionally, thrice daily doses of 1 milligram per kilogram are sometimes given when gentamicin is used for synergistic therapy. Vancomycin is initially given as a loading dose of 25 to 30 milligrams per kilogram IV in the critically ill, followed by doses of 15 to 20 milligrams per kilogram BD or daily, depending on the patient's weight and renal function. Both antibiotics rely on therapeutic drug monitoring for dosage adjustments. For vancomycin, this involves measuring the trough concentration before the fourth dose is given in patients with normal renal function, but this can be measured sooner in patients with impaired renal function. The target trough concentration is usually 15 to 20 milligrams per litre, but can be 20 to 25 milligrams per litre in those with CNS infections. Gentamicin monitoring is not necessary if therapy is going to be ceased within 48 hours, but should be done in patients with deteriorating renal function, those who are critically ill, or if therapy is known to be going to continue for over 48 hours. Monitoring is done daily to twice weekly depending on the situation and utilises either trough levels with a target of less than 1 milligram per litre or a computerised 24-hour area under the curve method. In terms of the distribution, vancomycin has a small volume of distribution of 0.4 to 1 litre per kilogram and is approximately 50% protein bound. Gentamicin has very low protein binding of less than 30% and a volume of distribution of 0.3 litres per kilogram. Both antibiotics are widely distributed into all body fluids except have poor CSF penetration, although this improves for vancomycin when the meninges are inflamed. Both vancomycin and gentamicin do not undergo metabolism, but are excreted unchanged in the urine by glomerular filtration. Gentamicin has a half-life of 2 to 3 hours, whilst vancomycin has a half-life of 4 to 6 hours in patients with normal renal function. The half-lives of both these drugs increase as renal function deteriorates, necessitating dosage adjustments in patients with renal failure.
I think it's really important to understand these two drugs because even though we don't use them quite often as penicillins or cephalosporins, these drugs can actually lead to quite nasty toxicities. So it's very important to understand their usage. Now, very important point that you mentioned about gentamicin is a concentration dependent killing. And you need to give a loading dose. Without loading dose, gentamicin will not be effective in killing the gram-negative bacteria. Also, with the vancomycin, sometimes we use in ICU as an infusion, but it's very important to keep monitoring the levels, especially with deteriorating renal function, because the vancomycin levels can really, really go sky high if the patient's renal function deteriorates, which is quite likely to happen in intensive care patients. So they're really, really important drugs that every trainee should know about. Now, another commonly increasing bacteria in ICU is VRE, that is vancomycin resistant enterococcus. Can you please list some of the mechanisms of resistance?
Yes, so VRE are gram-positive gamma hemolytic cocci that are resistant to vancomycin. The two most clinically relevant species are Enterococcus faecalis and Enterococcus faecium. These enterococci have intrinsically low pathogenicity but have a high resistance to antibiotics. E. faecalis infections is usually less severe compared to that of E. faecium. However, E. faecium is also more resistant to carbapenems and penicillins and is much more likely to be resistant to vancomycin compared to E. faecalis. The mechanisms of antibiotic resistance for these pathogens are fivefold. So one is for mutations in penicillin binding proteins. They generally have an already low affinity to beta-lactams, and then further mutations reduce the affinity further. They also can produce beta-lactamase, which destroys the penicillins. The third mechanism is by aminoglycoside modifying enzymes, which is where they produce an enzyme that inactivates aminoglycosides. The fourth mechanism is by antibiotic drug efflux pumps that pump out the antibiotics so that they can't reach their target sites. And the fifth mechanism is alterations in cell wall components. So this is the usual mechanism of vancomycin resistance. The D-ALA binding site, where vancomycin normally binds to, is modified so that the terminal ALA is changed to a lactate. And this doesn't allow vancomycin to bind to the enterococci.
Okay, as you mentioned, most of the antibiotics are actually ineffective against VRE. So, which antibiotics will you choose to treat VRE infections?
So this depends on antibiotic sensitivities and the illness, but options include linezolid, teicoplanin, tigecycline, or daptomycin.
Okay, so let's move on to one of the most broad spectrum antibiotics, or we can call it as one of the strongest antibiotics that we use sometimes in ICU, that's meropenem. Can you briefly outline the mechanism of action and spectrum of activity of meropenem?
Meropenem is a broad-spectrum carbapenem beta-lactam antibiotic. It interferes with cell wall biosynthesis by binding to penicillin binding proteins, resulting in bacterial cell death. It is highly resistant to degradation by beta-lactamases and produces time-dependent killing. Meropenem has a very broad spectrum of activity and is generally used for empirical treatment in patients with life-threatening infections who have penicillin hypersensitivity, for the treatment of known or suspected multi-resistant gram-negative infections, for empirical treatment of necrotizing skin or soft tissue infections, and for the treatment of neurological myeloidosis. Meropenem covers some gram-positive organisms, including MSSA, Enterococcus, and Streptococcus species. It does not cover MRSA and mostly doesn't cover ampicillin-resistant Enterococcus faecium. It covers most gram-negative organisms, including ESBL, Acinetobacter, Citrobacter, Enterobacter, E. coli, H. influenzae, Klebsiella pneumoniae, and Pseudomonas. It does not cover Strenotrophomonas maltophilia. Meropenem also covers most anaerobes, including Bacteroides and Peptostreptococcus.
Now, I hope after the Easter, you have forgot to ask your jokes or questions.
Nah, it's basically the highlight. So I've got one, it's Easter themed.
Oh my goodness. Okay, let's try that out.
Okay. Why was the Easter bunny so upset?
Oh, come on, Maddie. It's a happy season. Why Easter Bunny was so upset? Because he got registered.
No, he was having a bad hair day.
That was cute. Thanks, Maddie. So, folks, that was the end of our podcast for Antibiotics 3. So, next time we'll be back with antivirals and antifungals. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.